Hi everyone, welcome to Pulmonology Read Aloud. On this video on air travel guidelines for respiratory diseases, this is the British Thoracic Society 2022 document Read Aloud. Thank you for liking and subscribing to my channel. Thank you for appreciating the bronchiectasis series videos. If you haven't had a look on my past videos, then please see the link attached. Let's get started. So, a lot of you had asked me to make a video on air travel guidelines for passengers with respiratory disease, and the most recently published document on this has been the BTS document, which was published in 2022. And this document has major revisions as compared to the previous way we used to approach patients with respiratory disease who were traveling by air. Now, this document is mostly divided into two portions. The first one deals with fitness and recommendations, and the second one on individual conditions and specific requirements. In this video, I'll be talking about a general approach to a patient with respiratory disease who wants to travel by air and about the need of oxygen supplementation. So now you would agree with me that the maximum altitude that the flight achieves is determinant of the amount of hypoxia that we can expect for a patient. Now, in normal conditions, a altitude of 8,000 feet or 2,438 meters is achieved by most airliners. Now, why this 2,438 meter has been taken as the altitude that most airliners would try to achieve in normal conditions and not above that is because of the oxyhemoglobin dissociation curve will still stay above 90% in most average healthy individuals. So airlines would avoid going above 8,000 in general. However, there are instances where the altitude achieved is above 10,000, especially in airlines that cross zones, in international airlines, and that is where there will be an issue with oxygenation, especially in patients with chronic respiratory illnesses. There are certain airlines like the Boeing Dreamliner that can fly at a much lower altitude. So, the altitude that is achieved by the airline during its course is really determinant on how a patient with a respiratory illness will behave. So, whenever your patient asks you the question about that he is going to fly and he would need to know whether it would be safe for him to fly, there are a lot of factors that one must consider. And the first one, as I said, would be the altitude. And the second one would be the duration of the flight, because we would know that this flight would operate at this altitude for these many hours, and these many hours your patient will be in air. So, again, it will directly relate to what will be the outcomes. What are the timings of the flight? That also affects how this patient is going to be. What is the altitude destination? So, is he going to the hills? Is he going to the lowlands? So, what is the altitude of the destination? What is the weather? Definitely, that directly doesn't relate to our air travel related, but how your patient will respond once he reaches there, and what are the equipments that he's planning to carry. Does he use a PAP device? Does he use an oxygen concentrator? What is the weather where he's reaching? What is the weather in the zone that he's traveling to? And will his device still be operational to full capacity at his destination? So, these are the factors that have to be considered whenever we are met with this question. Now, The recent guidelines, the BTS 2022 guidelines, have had a lot of developments as compared to what was recommended for air travel in the past. And one of the major recommendations or development is regarding the use of hypoxia challenge test. So, hypoxia challenge test versus doing other arbitrary tests or indirectly trying to determine whether a patient will require oxygen. So that is one of the major developments in this guideline. The second thing, as I said in introduction, is that it answers a lot of queries about individual patient groups, and we can take it up as in a separate video. The third is also the importance of the equipment that is used for oxygenation. And here, the equipment mostly used and allowed by airlines for oxygen delivery includes the portable oxygen concentrators. So, portable oxygen concentrators, there are a lot of things around them that have to be considered before prescribing, before informing the patient of that choice, and that has been all included in this guideline paper. Now, this statement broadly addresses both adults and children with the conditions or undergoing the following procedures. It includes patients who've had mostly airflow obstruction or obstructive airway diseases like asthma and COPD, patients with bronchopulmonary dysplasia, congenital lung diseases, cystic fibrosis, non cystic fibrosis, bronchiectasis. Another patient group of interstitial lung diseases and restrictive lung diseases, how air travel will be determined in those patients. Patients with pleural diseases, patients with infections, sleep apnea, thromboembolism, pulmonary hypertension, and others. So, this I'll cover in another part of my talk. But these are all these individual conditions where you can refer to the guidelines and you will have answers. So, how do you approach any patient who comes to you and asks about fitness or approval or your approval to fly? So, a pre flight screening is very important at your end. This pre flight screening involves the most common part of our attempt to diagnosing anything, which is the history. So, is your patient symptomatic? Is he right now in an exacerbation, or is this patient more or less controlled right now? What is his baseline exercise capacity? So, we are going to try to find out his reserve. Is he having any exacerbation or has had an exacerbation recently in the past few months? And how has his experience been in the previous travels? Has there been any episode in the past wherein this patient had issues with respiration? The other thing that you really want to know is the detail of the journey. How many flights is he changing? Is it a overhaul, or is he taking a connecting flight or a direct flight? What is the duration of the flight? Is he going to fly in the daytime or the nighttime? Is he going to be sleeping on the flight? If he's an asthmatic, does he have more episodes in the middle of the night? What is the altitude the flight is expected to take, and what is the altitude where he is arriving? What are the medical facilities available? Is he equipped to understand whom and where to report for emergency? And what is the return plan as well? So, all of this must be asked by us. And the third important thing that this guideline has really highlighted is the hypoxia challenge test. So, if you notice any concerns around these questions, you would be asking your patient to undergo a hypoxia challenge test. All right, so the guideline statement gives a very wonderful flowchart on how to go ahead and screen your patient for requirement of a hypoxia challenge test or in-flight oxygen. Now, if you come across such a scenario, the first question to ask is your patient hypoxic at present? So, if your patient is not hypoxic at present, his oxygenation is more than 95%, we need to see if he is dyspneic. If his MRC dyspnea score is less than 2, he's not hypoxic right now, then presumably he will not require in-flight oxygen and he will not require a hypoxia challenge test. However, if his dyspnea score is high, even though he is not hypoxic right now, you see if his SpO2 is less than 84% on a 6-minute walk test or a shuttle walk test. Now, if your patient's SpO2 does not fall, is not less than 84% on a walking test, he would probably not require a oxygen or hypoxia challenge test. However, if he does desaturate on the walk but was not hypoxic at baseline, we rule out a history of hypercapnia. And if there is no risk of hypercapnia, he's not a COPD, he is not a known hypercapnic, then just because he does desaturate on walking, we will consider an in-flight oxygen, which should be around 2 liters a minute. Now let's come to a scenario where your patient is hypoxic, his saturation is less than 95 when he comes to your clinic. In such a scenario, you find out if he's already on LTOT. If he's already on LTOT and pure hypoxic, no hypercapnia, you increase the prescription of the oxygen to 2 liters per minute more than his prescribed LTOT prescription. So he gets additional oxygen in the flight. But if he has hypercapnia, you would consider a hypoxia challenge test. And even if he is not on long term oxygen therapy but has been found to be hypoxic at your center, you would again consider risk of hypercapnia. If there is a risk of hypercapnia, it's important to do the HCT. There is no risk, we just consider an in flight oxygen at 2 liters per minute. Going further, sometimes it's also important to recheck if your patient who has a known chronic lung disease, so in case he has a restrictive respiratory disease, would this patient be a candidate for in-flight oxygen? So there's a separate flow chart for patients with restrictive lung disease as against the flow chart for patients with obstructive, where we would suspect hypercapnia much more. So in this one, we would see if our patient with a restrictive respiratory disease require in-flight oxygen or HCT. So again, start with his saturation. His saturation is not less than 95 even when he walks. If it's not there, then he doesn't require more oxygen, he doesn't require an HCT, and you can send him. If your patient is hypoxic and if your patient's SpO2 is less than 95 on 6-minute walk or shuttle walk test, then we need to again consider if he's on LTOT. If he is, then again, just like obstructive impairment, we here also increase the oxygen 2 liters per minute more than the prescription. However, if he's not on LTOT, then we see if your patient's PO2 is low on room air. So if his PO2 is less than 9.42 kilopascals, it is reduced, you see for his lung capacities. So is his TLCO less than 50% of predicted? So restriction is there, hypoxia is there. Then we definitely give him in-flight oxygen at 2 liter per minute, even though he was not on LTOT, but his saturation is low right now. Now, if your patient is not on LTOT, he is hypoxic, his PO2 is not low. Then, if his TLCO is less than 50% predicted, so there is a severe restriction, you would consider an HCT. But if there is not a severe restriction, TLCO is more than 50, you will not give him in-flight oxygen or send him for HCT because his oxygenation is good. And same ways, if the TLCO was not less than 50% of predicted and his oxygenation was not low, then he might not require in-flight oxygen. And if it was not severe but his oxygenation was less than 9.4, he would require 2 liters per minute in-flight oxygen. So it's really simple to understand that if you have an obstructive lung disease, hypercapnia is something you really want to be sure of before you prescribe him oxygen. And if you have a patient with restrictive lung disease, you need to see if he has hypoxia, if his PO2 is low, and you also want to see what is the level of restriction that his patient has. Now, where would you not ask for HCT? Let's try to compile those situations. You would not ask for HCT if your patient is stable, if your patient had a previous HCT which was fine, He's not had an exacerbation and he's asymptomatic and not hypoxic. In a COPD patient, if his SpO2 is more than 95 and his dyspnea score is less than 2, or his 6-minute walk desaturation is not less than 84%, you will not require an HCT. If his saturation drops more than 84%, you would require a hypoxia challenge test. Also, in a patient who's had a previous history of a respiratory distress in flight of any kind, we will not do an HCT. We will just give him empirically oxygen at 2 liter per minute if there is no hypercapnia. So that's how we would judge whether you should send him for a hypoxia challenge or not. Now, coming to patients where you would consider hypoxia challenge, these would be COPDs with an SpO2 of less than 95 at resting, an MRC score of more than 3, or a desaturation on 6-minute walk less than 84, right? And a concern for hypercapnia. These would also include severe asthmatics. So, severe asthmatics who have persistent symptoms, who have repeated exacerbations despite treatment, regardless of their oxygen level, you would consider doing a hypoxia challenge for a severe asthmatic. For ILD patients who are hypoxic with SpO2 less than 95 on exercise, or have a resting PO2 less than 9.42 kPa or a TLCO less than 50, you would do a hypoxia challenge test. For patients with severe respiratory muscle weakness, restrictive lung disease like chest wall deformity, where the FVC is less than 1 liter, just like we do for fitness for surgery, if it is less than a liter, you would consider an HCT. Any patient with hypercapnia, risk of hypercapnia, and those who are taking medicines which cause respiratory depression, we would do an HCT. Or patients who have a history of type 2 respiratory failure, who are on LTOT, we would do that. However, if there is no evidence of hypercapnia, you can just increase their oxygen by 2 liters from the baseline, and make sure that the equipment that you are sending with them can provide that additional oxygen of 2 liters. What is the procedure of performing an HCT? The hypoxia challenge test is done by making the patient inhale 15% oxygen. So we have to use an inspired gas which gives them 15% oxygen, which is approximately similar to the inspired oxygen tension at breathing air at the maximum allowing cabin pressure altitude, which is 8,000. So even if your flight is maintaining an altitude of say 13,000 feet, if the cabin pressure maintained is of around 8,000, at that 15% is what we would be expecting. It must be performed in a specialized respiratory physiology unit. Now, how do we achieve this 15% oxygen? 15% oxygen gas mixture can be achieved by either using a cylinder, a pre-mix cylinder, which has 15% oxygen. Medical gas providers can give us such cylinders. Sometimes nitrogen can be introduced into a chamber like a body box, especially when you are dealing with pediatric patients. They can be made to sit on the lap of someone, and we can introduce nitrogen to make the oxygen concentration 15%. Here we would not need a face mask then because it's in a body box. But the adult who's undergoing that test with the patient, with the child, will also have to undergo monitoring, SpO2 monitoring, to see if this patient develops hypoxia during the test. What we can also do is we can use a 40% Venturi mask, and that can be used with pure nitrogen as the driving gas. So the total FiO2 would be 15%. Sometimes hypoxic gas generators like oxygen concentrators can be used to provide variable hypoxic gas mixtures, and Douglas bags can also be mixed with air or nitrogen, and this way we basically reduce the inspired FiO2 to 15%. And we can use a tight fitting face mask in a closed circuit or in a body box. We can do it even without masks. The technique. So basically, you make the patient breathe the hypoxic gas mixture for 20 minutes or until his SpO2 drops to 85%. Now, if your patient's SpO2 drops to 85%, then he's advised to have in-flight oxygen. So if your patient has a PaO2 less than 50 or 6.6 kilopascals, or SpO2 drops less than 85%, by giving 15% inspired oxygen, that means it will drop in the flight too, and that's how you will prescribe him oxygen. Here, it's important that the way you're measuring the oxygenation is very important. So, your monitors should be rapid response analyzers and monitors to catch those more quickly. And a routine pulse oximeter may not be the right way. And ideally, though, we would need an ABG, that would be the gold standard to check the PO2, but sometimes that's not possible. And then SpO2 of 85 has been used by the guidelines as a surrogate marker. And because we're making them breathe this whole mixture for 20 minutes, this is actually shorter than the briefest flight that you will have to be. The flight would be much more. So, why would we still take this 20 minutes and why not make them breathe it throughout the duration of the flight? Because it's expected that oxygenation equilibrium will be reached within 20 minutes and you would see the changes in the oxyhemoglobin dissociation and thus changes in the oxygenation. How do we assess what flow rate to give to the patient? So whenever we do the HCT and we see there is a hypoxia, we titrate it. So a titrated HCT can be done using a pulse dose oxygen, and we want to maintain a PO2 more than 6.6 kilopascals or SpO2 more than 85. Here a pulsed dose delivery is used, but for young children pulse dose may not be suitable. Or if you're talking about OSA and hypoxia in CPAP use during sleep, you may not be able to do it. And then we will have to also think of how we will be delivering oxygen in the flight. Also, if you look at the previous BTS recommendations, they mentioned that in-flight oxygen should be 2 liters or 4 liters via nasal cannula. And so for many years, they just gave a fixed flow rate because that's routinely available on an aircraft and it's difficult to get a flow rate higher than that. But here we would want to titrate the HCT and achieve that oxygen level. So we start with setting 2, which approximates to 2 liter, but we're looking at that level of oxygen where SpO2 is above 85. Now, if pulse dose oxygen delivery at higher settings isn't sufficient to maintain the PaO2 at more than 6.6 or more than 85, then we have to recommend continuous oxygen, and hence here it's important to see what kind of oxygen he's carrying in the flight. Because in flight, the POC models that one can carry, if you look at them, they are mostly in pulse mode, they're not in continuous mode, and they would not supply more than 3 liters per minute. It is, however, very essential to remember and to tell the patient that a hypoxia challenge test is not a fitness to fly test, and you can actually call it as pre-flight oxygen test, which is more descriptive. However, the guidelines have still incorporated this term HCT. If you look at the general airline requirements for patients who require additional assistance, usually there is a big form that has to be filled out and signed by healthcare professionals, which includes lot of other parameters regarding the mobility of patient, regarding his need for any emergency medications in the flight. So a complete fitness to fly or an in-flight assessment is a whole conundrum of which HCT may be a part. Now, this flowchart again taken from the guidelines, and there's another flowchart which very nicely now briefs out and consolidates all the information that we've gathered so far. So now your patient meets criteria for HCT. You've done all of those criteria. You give HCT, 15% oxygen, 20 minutes, and you monitor his SpO2. SpO2 falls less than 85%, either you do an ABG and or you are checking for SpO2 and you directly proceed with oxygen. So this is titration. Now you've done an HCT with oxygen for 20 minutes, you titrate as required. Once you do that, is PO2 more than 6.6 achievable with the flow rate of 2 liters? Now, you cannot do that, and higher flow rate is not possible with the kind of equipment he has, then your patient is not suitable for air travel. If you can achieve this much oxygenation with the available flow rate, then you see if his PCO2 has increased. So here ABG has a lot of importance and is indispensable. If his PCO2 has increased by more than 1 kilopascal or his pH is less than 7.35, so he has hypercapnia, he is not fit for air travel. If your patient has not achieved that, then you can recommend an in-flight oxygen at a flow rate to maintain oxygen more than 6.6. Now your patient, where you did the HCT, his SpO2 remains normal. If it does, his oxygenation is not required. But if it drops less than 85 or between 85 and 90 after 20 minutes, then you check if his PO2 is more than 6.6 without oxygen. If it is, in-flight oxygen not needed. If it's not, then you go ahead and do the titration. So this is in a nutshell what will happen after the HCT. So what do we do about patients who have hypercapnia? So if your patient has a very high risk of hypercapnia or respiratory acidosis, then that precludes this patient from in-flight oxygenation and travel. So especially for patients when you find there is hypercapnia during the HCT, in such patients or patients with history of hypercapnia, blood gas sampling becomes very, very important. And you have to deliver the minimum amount of oxygen here to keep the PO2 more than 6.6, and you have to monitor the PCO2 and pH at that time. If you do not have blood gas sampling, which is not ideal, then we must try to keep the SpO2 as we do in all COPDs between 88 to 92 or above the resting level with supplementary oxygen, but that's not the ideal scenario. Summarizing, a negative hypoxia challenge test where in-flight oxygen is not considered necessary takes around 20 to 30 minutes. If you require an oxygen titration, this patient will be there in the lab for around 60 minutes. You would not need oxygen if the PO2 is more than 50 or 6.6 kPa or SpO2 is above 85. You would recommend in-flight oxygen if it's less than 50, SpO2 less than 85, and you would titrate oxygen to maintain a PO2 more than 6.6 or SpO2 more than 85. And if there is hypercapnia, you would ask the patient not to fly at this point of time till he's optimized. There is a very good video, an informative video available on the European Lung Foundation website on Are You Fit to Fly? You can show your patients this video, and if you're setting up an HCT unit in your hospital, this will come very handy. Lastly, one mention about the POCs or the oxygen concentrators. Now, it really depends on the airline which the patient is flying, whether it's domestic, international, about what kind of equipment is allowed. So, there are few airlines, few of them who also supply their own oxygen and then they charge the patient for that extra oxygen. So, your patient needs to take all that information from the airline, what their charges will be, how the charge will be determined, is there a specific price structure, and what kind of a POC will they be providing? Will it be pulse mode or continuous mode? What is the maximum amount of oxygen it can liters you can go up to? And for example, most common flow options, there would be only one or two choices. They would say either 2 liters or 4 liters per minute, but some will have adjustable ranges. You have to make sure that the patient knows whether the nasal cannula will be given in flight or a rebreather mask is available. Which one would he have to choose? You have to let him know. So, all of that is important. And it's also very important for the patient to verify the arrangements, verify the equipments, make sure he checks with the dealers that it works at a particular altitude in the same efficiency or at a particular weather condition. And whenever the patient makes reservations with the airline, they have to tell them about all these questions and concerns much in advance. Commonly, the POCs are available like this, like portable bags. Again, you have to see about the charging, the power supply source, and others. So it's really a complicated decision when you're dealing with chronic respiratory illnesses who have to be in flight, because there is a lot of cost involved in case a patient gets serious in flight and the flights have to be diverted or an emergency landing. Not only for the patient, it is a very big risky situation, but also for everyone on board. So we have to choose our answers more wisely and with more evidence. So, thank you very much for tuning into my video. I will be making another video on the individual conditions that have been enumerated in the guideline statement. Please keep liking, subscribing, and spreading my channel. Thank you.